It's my honor and pleasure to introduce Dr. Janet Pope, who is a professor of medicine in the Division of Rheumatology and also epidemiology and I can never say this, biotoxicity at the University of Western Ontario, Schulich School of Medicine in London, Ontario. She is the division head in rheumatology at St. Joseph Health Centre in London. She obtained her MD and her fellowship in internal medicine at UWO and a fellowship in rheumatology and Masters of Health, Public Health in Boston University. She has completed a Canadian Arthritis Society Research Fellowship in Scleroderma. She's a founding member of the Canadian Scleroderma Research Group and is the vice president of CANOLIS, Canadian Network for Improved Outcomes in Systematic Lupus Entomologist. She is on the executive of the Canadian Rheumatologist Research Consortium and contributes to the advisory board in Scleroderma, RA, and lupus. So Dr. Pope, welcome, and thank you very much for your presentation today.
Great, and thank you, Sharon, for the kind introduction, and thank you everyone for attending on a Friday afternoon, and I think some will be looking at it non-live in a future time too, which is really great. So one thing about COVID is we've learned to master Zoom pretty well. So I welcome questions. Feel free to put them in the chat at any time, and Sharon will help moderate questions. So I will be talking, sometimes you'll see slides, and I will put it into lay language, don't worry, okay? So I'm gonna talk about interstitial lung disease, including pulmonary fibrosis, and how it's in rheumatology. So rheumatoid arthritis and scleroderma, I'm mostly going to talk about. And I do consult for lots of groups, and I'm on lots of committees with my Canadian Rheumatology Association and my Ontario Rheumatology Association. So we want to talk about, well, who's going to get it? So risk factors for getting inflammation in the lungs or interstitial lung disease and rheumatoid and scleroderma, and a little bit about other connective tissue diseases. Look at how common it is. So some of these conditions are common, and interstitial lung disease is rare within the conditions, like rheumatoid, or at least uncommon within the conditions. Scleroderma is rare, but interstitial lung disease and scleroderma is actually very common. And having lung involvement, unfortunately, does increase mortality. And then to look that there is hope, there's lots of research, and there are treatment strategies now. So I'm going to use two terms, and they're not exactly the same. And so thanks to Wikipedia and other websites for telling me how to define the terms more in lay language. So I will talk about interstitial lung disease, and we also call that ILD. And that's used for a large group of diseases. And I'm going to talk about these autoimmune rheumatology diseases, connective tissue diseases, and rheumatoid arthritis. And they cause scarring in the lungs, may cause. And scarring is also known as fibrosis. And there's a whole bunch of other causes of interstitial lung disease. So the scarring can stiffen the lungs. So it's harder for the lungs should be a nice sponge. And if they're firm, it's not a sponge. So the transfer of oxygen and carbon dioxide is changed and worsened. And the damage can be irreversible. A result of interstitial lung disease in some people will be permanent irreversible scarring, and that is called pulmonary fibrosis. So lung diseases that are causing lung tissue to be damaged and scarred, so it's the alveoli and the interstitium of the lungs that are getting scarred and damaged. And by damage, it's thickened. We can't reverse it at this point in time, at least. And so not all of interstitial lung disease goes to pulmonary fibrosis. So when I use the terms, at least, you know, interstitial lung disease could lead to this irreversible damage, but in some people it doesn't. And that way you'll know kind of the difference. So some patients will have fibrosing or scarring interstitial lung disease from lots of causes. So people are familiar with IPF, idiopathic pulmonary fibrosis, but there's all sorts of other things. Sarcoidosis that you will have a lecture on or already have. I welcome you to join and hear that one. Other things like IPF is the one that we talked about, but I'm going to talk about autoimmune diseases related to interstitial lung disease. But there's some allergic causes that can do it, and there's a whole bunch of other causes. So mine will be autoimmune connective tissue diseases, so rheumatology type conditions. So when we look here, you can see basically that many connective tissue diseases are associated with interstitial lung disease. So I will talk about rheumatoid. I'll talk about scleroderma. I won't talk too much about the other ones, maybe 1 or 2 slides only on inflammatory muscle condition of dermatomyositis or polymyositis. But lupus can, not so commonly. Sjogren's can, not so commonly. So rheumatoid arthritis we'll talk about first. It affects 1 in 100 people in Canada. It's more common in women, about 80% women, 20% men. And it's autoimmune. So often there's a rheumatoid factor or another autoantibody, but you don't have to have those antibodies. You can still have rheumatoid arthritis and not have those blood tests positive. It can cause damage in the joints, but it can affect other organs. So lungs that we'll talk about, but also eye problems. It increases the risk of heart attacks. So there's a lot of other organs beyond the joints that can be affected. And these are some pictures. So the top one there, you see the damage of the fingers here, an x-ray showing a lot of damage. There should be good joint space there, and no of that white chalky change shouldn't be there. The joint spaces are narrowed. This is a lung involvement of a patient more with rheumatoid nodules, and that's those 2 arrows that you can see. The circles are rheumatoid nodules. You can see hands here that still have some inflammation and are already malaligned. You can get rheumatoid nodules at your elbow, and this is a patient of mine with very severe damage. So the most common lung pattern is the usual interstitial pneumonitis pattern, and the usual is the same kind that's in that idiopathic pulmonary fibrosis or IPF. It occurs in 3 to 5% of our patients. The interstitial lung disease, that's quite severe, but overall interstitial lung disease, even less severe, is probably double that. So 7 to 10% of our patients. It's more common if they have positive rheumatoid factor, more common that men with rheumatoid get interstitial lung disease, but more women have rheumatoid arthritis. And maybe our native peoples have an increased risk, and I think they probably do, for interstitial lung disease. So I'm going to give you key messages and then go into them a bit. So interstitial lung disease, if you say it's 1 in 10 of our rheumatoid patients, or 10%, half of them are clinically relevant. And the risk is increased with increasing age, with disease activity, so active rheumatoid arthritis, inflammation in joints, and it's always increased with smoking. Methotrexate, our gold standard treatment for rheumatoid arthritis, does not worsen this kind of interstitial lung disease, and it may decrease the onset of getting rheumatoid lung disease. So in other words, methotrexate is good treatment for the joints in many patients and should decrease the chance of getting interstitial lung disease. However, methotrexate itself can cause a different kind of lung disease. Nintedanib is indicated for severe rheumatoid interstitial lung disease by Health Canada, and may be appropriate for some patients in my practice and other rheumatoid arthritis patients. Among biologic therapies, some evidence that rituximab, abatacept, and now Actemra, tocilizumab, the one you've heard about in the media, because Actemra or tocilizumab, same drug, 2 names, is indicated for severe COVID, making severe COVID less severe. And it might improve or maintain lung function, some of these advanced therapies or biologic drugs. And we do need larger studies to be helpful to clarify the best treatment options for our patients and where should we intervene for our patients. So this is one of my patients. So you can see she's had her shoulder replaced from her rheumatoid arthritis. So she's had severe rheumatoid arthritis for half her life. She's in her early 70s now. So she got it when she was in her early 30s. And you can see on the CT scan that it's on both the bottom of both bases there at the bottom of the lungs, but worse on the left than on the right, but on both sides. And you can see on the other image as well, again, worse on the left than on the right. So she has your normal lung function would be 80 to 120% predicted. So under 80% is quite abnormal. So her forced vital capacity is down, and her gas exchange, the diffusing capacity, is way down. And now she's on oxygen. So what you want to know is, why does it take so long to get a diagnosis of interstitial lung disease or pulmonary fibrosis even when you're followed by a specialist. What's going on? Well, I know about this. Why did I only diagnose her when it was so late? And here's why. First of all, it's not always relevant for our patients. It can be sneaky until it's really clinically relevant, so almost silent, and then it becomes really bad in some patients. But here's also why. The lung manifestations of rheumatoid arthritis are all these things. Holy smokes, there's a big long list of them. So when someone's short of breath, we investigate, but they can have interstitial lung disease and it can be very silent. And then all of a sudden, maybe they aspirate, maybe they get a viral illness, and then their lungs go nuts because it wakes up this inflammation in their lungs. And in some people, it will lead to fibrosis. That's the irreversible scarring. So it takes a long time because it can be silent at first, and because there's a broad differential, we have to figure out you could be short of breath for a lot of things from your rheumatoid, but also other people are short of breath because they have asthma and things like that. So what are the risks of getting interstitial lung disease? So smoking. So my patient was a woman. Men have a higher risk, but women are more common to have RA. She's a lifelong non-smoker. She never lived with a smoker. She had no secondhand smoke exposure. Some genetics as well are a risk. So we don't go and do the genetic profiling of all our patients. And then environment. There's triggers that can increase the chance, and they could be, as I say, local things like aspiration in your lungs. So you cough and choke at night a little bit. We all do possibly, but this would be more and inflaming the lungs from the acids in our stomach or the food contents. That's a risk, more in scleroderma than in rheumatoid, and having those positive antibodies. And my patient was very strongly antibody positive for rheumatoid factor and the other one called ACPA, or the citrullonated protein. So even at time of diagnosis, though, our patients can have more lung problems. So this was looking at 11,000 patients with new rheumatoid arthritis in Sweden, and then they looked at control population, age and sex matched, and even the region of Sweden matched. And there were more even lung problems early on. So respiratory problems at the beginning of your rheumatoid arthritis were about 1.6. So that's about 60% higher than the control population. So not double, but 0.6 higher. So 1.6 higher. So even at the beginning, you can have some lung issues. And this is this large study from the UK where they've looked at thousands of patients doing breathing tests, more to get norms and to do research, not because they're looking for problems. But you can see rheumatoid arthritis had more severe restrictive lung disease pattern than age and sex matched controls in the UK, but also more obstructive pattern, and that would be severe obstruction like obstructive lung disease, COPD, or emphysema. So already our patients, before they get their RA or at the time they get their label, have more problems going on than the general age and sex matched population. But most of them don't have lung problems, but they have it in a higher rate than the population you would expect. And to do, for some of you, you have seen or done lung function tests. So you're in the box and they go blow, 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 and it's horrible for you with the tube. Not everyone loves it, but some of you get very used to it. And these are one of my patients, and we just look at the percent predicted. So she's got a restrictive pattern and her gas exchange is quite low. In this case, it's half of what would be predicted, 49% predicted. And it's restrictive, so the patterns are shrunken volumes. Flow is reduced as well. It's not obstructive in this person. And these are patterns that we can see on the high resolution CT scan. So I showed you my one patient who had the shoulder replacement, what her pattern looked like. So this is the worst is the honeycombing with the UIP pattern. And again, you can see it's maybe a bit asymmetrical, but it's on both sides. You can see this other pattern on B, where it's the non-specific NSIP. So for all connective tissue diseases, except for rheumatoid arthritis, the most common pattern is B, but rheumatoid arthritis, the most common pattern is A, and A is a worse pattern because you can't make that get better where the holes, the gas exchange units in the sponge has gotten bigger holes. We can't put that back together at this point in time. And then there's a pattern C that's less common. So the most common is the usual pattern. And that A pattern, the usual one, is what's most common in IPF. So patients with interstitial pulmonary fibrosis, that's idiopathic as well, have that pattern. So more damage on the lungs equals worse survival. And that's all these holes here in that patient A. You don't want those holes because you can't get them better of the holes. You can try to decrease progression, but they will progress over time. So if you have more damage, more distortion of the lungs on the appearance, that's bad. And having fluid on the lungs, well, it's outside of the lungs, pleural effusion is also worse prognosis, and I don't know why. A better prognosis would be these patients that have these fluffy infiltrates, and you go, well, that looks really bad. There's all this fluffy stuff, because some of that will go away with immune suppression. So B has not led to a bunch of damage. A is a bunch of damage, different patterns. So why is it important to diagnose interstitial lung disease and rheumatoid arthritis? Well, we want to improve their quality of life, and we'd like to increase their quantity of life. So we want to prolong survival, and we want to make people feel better. So we know that survival is reduced in people with rheumatoid arthritis having lung involvement than if they don't have lung involvement. We also know that the worst pattern is definite or possible UIP pattern. That's the pattern with all that damage, and it has the worst survival. And the survival is equivalent to IPF if you have that pattern. The idiopathic pulmonary fibrosis group that we're not talking about, that's a different condition. That's IPF. We're talking about rheumatoid lung. So they have survival that's just as bad as them if they have that pattern. We also know that the incidence of rheumatoid lung in this study is 9 times higher than age and sex matched general population. And it's even starting at time of diagnosis and increasing over time. And it does worsen your survival. We also know overall, some good news is that the death rate of rheumatoid arthritis overall is going down in men and women. Women are the squares, men are the triangles. So it's going down in both groups. But if you have interstitial lung disease with rheumatoid arthritis, that's the second panel, it's actually going up. So overall, rheumatoid deaths going down, rheumatoid interstitial lung disease, more death. It's this, the survival's decreasing. And you'd wonder why? Well, it's probably because of the fact that age is a risk, and older age of onset or longer rheumatoid disease duration, our patients are living longer. Age worsens ILD, no matter what you got interstitial lung disease for. Also, if you have that UIP pattern, you have that poor prognosis, and that's the more common pattern on our rheumatoid patients. So look down here, mortality from RA ILD is increasing, but it's only really increasing excessively in the older age group. So you see some minuses. It's actually improving your survival. Minus is better, by the way. And the 45 to 54 age group, 55 to 64. But when you come down to 75 or even over 85, we have higher mortality in that group because age worsens your lung disease, as does longer disease duration. So what are the risk factors? So not every study agrees, but if you already have bad lungs to begin with, you're more apt to get interstitial lung disease. So if you already have obstructive lung disease from your RA and or from your smoking, because not all RA patients smoke, and some non-smokers with rheumatoid arthritis still can get emphysema. Emphysema or obstructive lung disease, or what you know as COPD, chronic obstructive pulmonary disease, increases your chance of interstitial lung disease. So does rheumatoid disease activity. So we have to try to control the patient's rheumatoid joints. And so does having a positive antibody. And so does having inflammation. Not all studies agree, but they're the main risk factors. So in this study, you have about an 8% chance of ever having rheumatoid arthritis, interstitial lung disease. So rheumatoid is 1 in 100. So rheumatoid arthritis with lung disease is about 1 in 1,000 if you say it's in 10% of our patients. So that's why it takes a long time to diagnose their lung disease. It's not so common in our rheumatoid patients. It can be sneaky or insidious until it blasts off and is bad. And because we don't know who's going to get it, because I have lots of patients with severe rheumatoid rheumatoid arthritis who don't have interstitial lung disease right now. So we also know here that half our patients with rheumatoid lung onset their lung disease early, but it doesn't mean it was always clinically relevant. So you got to follow those people if they have crackles when we listen on exam. So we hear the lung disease, and also we often do a chest x-ray at the beginning of their rheumatoid arthritis. And we always do a chest x-ray when we start the first advanced therapy, like a biological drug. So then we can pick up the lung disease in those times too. So this shows that if my patients are in remission, the chance of getting interstitial lung disease is far less than if they aren't in remission but have low disease activity, which is still less than if they have moderate disease activity, which is still less than if they have high disease activity. So this is one reason of many why we should try to control rheumatoid arthritis and get patients into remission. We also decrease heart attacks if patients with rheumatoid are in remission. We decrease joint damage, and we maintain their function better of their hand function and elsewhere. So lots of good reasons to try to get our patients in remission and keep them there. So there is a dilemma. This is why I can't diagnose everybody early. We can't predict who will have it. We know the risk factors, but there's lots of my patients with these risk factors who will never have interstitial lung disease. Not all of interstitial lung disease is clinically relevant, and we don't really screen for it because respirologists would say they'd screen, but rheumatologists don't screen because we have lots of rheumatoid arthritis patients and we have to choose wisely on resources. So we often screen if we hear something on the physical exam, listening to the lungs, if we see it on the chest x-ray, or if the patient has shortness of breath. So often I pick it up when it's kind of late, but the main treatment early would be please treat the rheumatoid arthritis joints very effectively, which I'm trying to do anyway. So myself and others were actually working on a screening tool to help my colleagues with rheumatologists with their RA patients. So the treatment is 2 steps. Treat the underlying disease, so treat that rheumatoid arthritis inflammation highly effectively, and treat the lungs with anti-inflammatory immune suppressive treatment, and then treat with antifibrotics. So we are treating with immune suppressives and antifibrotics. So 2 approaches, usually one then the other, and sometimes 2 together. So, and the treatment of rheumatoid lung might vary compared to connective tissue diseases. So I'm putting this up here not to discuss it, but just to see there's a whole bunch of different treatments we talk about. And rheumatologists know this stuff. So they know the summary of how to treat initially connective tissue disease associated interstitial lung disease. So we also know that methotrexate use decreases interstitial lung disease and rheumatoid arthritis in all these studies. So decrease, but as soon as someone has interstitial lung disease, the respirologist says, stop the methotrexate because methotrexate can give interstitial lung disease. And if a patient has interstitial lung disease and gets a drug side effect on top, maybe that'll be really bad. But if we stop methotrexate, their lung disease can progress. So we have this sort of battle between rheumatologists and respirologists, and usually we both win the battle. We come to some conclusion that's right for the patients. So there is a treatment algorithm, and really to follow carefully to do the pulmonary functions in the high resolution CAT scan or the CT of the chest to look at their lungs, to follow periodically, to change treatment if things are worsening. So there is a algorithm that often respirologists would follow, but because I have an interest in this area, I tend to know the algorithm pretty well too. Treatments, there's guidelines, and the treatments, by the way, a lot of these treatments are anecdotal when we talk about the advanced therapies. So cyclophosphamide, mycophenolate mofetil, they could be used. Mycophenolate mofetil is also known as MMF, Cellcept, or Myfortic. But the advanced therapies would be abatacept, rituximab. Now tocilizumab has data in scleroderma, so we wonder if it's somewhat protective in rheumatoid. And then some pills that are advanced therapies called the Janus kinase inhibitors, or JAK inhibitors, or JAKs. So we have some other potential treatments, but we also have Health Canada approved nintedanib. So that's, I talked about the immune suppressive pathway, I just did. Now this is looking at the antifibrotic pathway. Antifibrotics do not reverse the inflammation. They try to reduce or slow the progression of damage over time. The other drugs that I just talked about over here, these biologics and other drugs, are to stop inflammation or reverse. These antifibrotics, like nintedanib, are to slow the progression of disease. So to get worse, less. So, and this is a study that shows it. So these are patients from a large randomized controlled trial looking at rheumatoid arthritis patients, as well as other patients with progressive pulmonary fibrosis. You can see placebo, this is losing lung function. So you want to be as close to zero as possible. So you lost double the amount of lung function on placebo as you did on the active treatment nintedanib. And another way of looking at that is it's always favoring active treatment, nintedanib, overall compared to placebo. And in every group we look at, including the ones I'm interested in, rheumatoid patients, scleroderma patients, mixed connective tissue disease patients, and other fibrosing interstitial lung disease. You'd say, oh, but those lines, there's a lot of width around them. It's because the smaller the sample size, the longer you have your confidence interval around it, but none of them are saying it's worse than placebo. In every case, you'd rather be on the favoring treatment than the favoring placebo. So that's the data. And then also severe worsening, you can see that the proportion of patients with severe worsening, either 5% worsening in lung function or even way worse, 10% worsening in lung function, you get less on the patients on nintedanib than on placebo. But look at, you're still getting worsening in 60% of patients on placebo for the 5% decline and 40% on the active treatment. And then the 10% worsening, which is really bad, over the randomized trial over 1 year, 1 in 3 progressed on greater than 10% in worsening of lung function on placebo, and 1 in 5 on nintedanib. So you want to be on the active treatment in these sorts of studies because the active treatment was effective of less worsening. There's also the other antifibrotics, so nintedanib, the other one is pirfenidone. There's a randomized trial in rheumatoid arthritis, and we don't have the results yet, but we'll probably get them. The estimated date of completion was January of this year. Then they have to analyze data, so we should know soon if pirfenidone works, but put it this way, it probably does as well. So the treatment of interstitial lung disease beyond what I talked about of immune suppression or immune modulation and antifibrotics is treating the RA effectively, getting patients to stop smoking, treating reflux. So barfing or aspirating into your lungs is bad. So acid reflux or GERD or gastroesophageal reflux disease is bad for anyone for any reason with interstitial lung disease, including rheumatoid arthritis. Getting people exercising, so you might send them for lung rehab. By rehab, I mean an exercise program. Giving them oxygen if they desaturate or if they have a low oxygen sat, even at rest, or desaturate with exercise or with lying down. Vaccinate everybody appropriately, so the flu shots, the pneumococcal shots, and also now COVID vaccine for everyone with interstitial lung disease should have their vaccinations up to date, and sometimes lung transplantation. A lot of my rheumatoid patients are too old to get a lung transplant by the time they have bad interstitial lung disease, but some have gotten lung transplants if it's not contraindicated and if they have very, very low predicted survival. So now we're going to move on to scleroderma. Unless, Sharon, was there any burning question that came?
No, not at the moment, Doctor.
Okay, so I'll invite people, use that chat and write a question. All questions are good ones, so don't be shy. So scleroderma is systemic sclerosis is the other name. So these are my patients who gave permission to show pictures of them. So this is a patient with puffy hands and puffy face. The other is a patient with later disease who has lots of the red dots on hand and on their face, who has claw hands that are really quite damaged. There's some other patients kind of in between that also can have inflammatory arthritis, but don't have to have it. So the lung disease and scleroderma is very, very common. Scleroderma is very, very rare. Scleroderma is about 1 to 2 in 10,000 people. but scleroderma in the lungs is about 1 in 3 of them. Whereas RA, rheumatoid, is 1 in 100 people, but about up to 10% will get lung disease from their rheumatoid arthritis. So it just gives you an idea. So we have this 15% rule in scleroderma. So about 1 in 3 will have interstitial lung disease, but half of them it's clinically relevant. So 15% will have the scarring of the interstitial lung disease, which is the pulmonary fibrosis. So that's 1 in 6 of my patients with scleroderma will die from their lung disease. So that's a lot of people. So recommendations were just published, so I'm giving you some new data. You're not going to read it all, but what's important here is for the interstitial lung disease, they say early diagnosis is essential. We want to stabilize their breathing tests. You could use cyclophosphamide or mycophenolate mofetil. And then on that's induction. On maintenance, you can use mycophenolate mofetil or azathioprine. You might consider rituximab, but now I told you abatacept, tocilizumab could be considered. Oxygen therapy if they have low oxygen. Nintedanib, if they have the progressive pulmonary fibrosis condition with it, the IPF kind of look with it, and lung transplantation potentially. So look here, it sounds a lot like rheumatoid, not exactly, but a lot like it. So we have other lung things that can happen. So 1 in 6 of my patients, or 15%, can have pulmonary hypertension, and 1 in 6 will have clinically relevant bad interstitial lung disease. So if someone's short of breath, I got to figure out why. They can also have heart involvement and be short of breath. But we're screening our scleroderma patients because it's so common. So we're trying to pick it up even before they're short of breath. So we did a large population study in Ontario over a decade by administrative billing codes. So we found 3,000 patients with scleroderma. And just like I said, 1 in 6 or 15%, we found 18% had clinically relevant interstitial lung disease, so 15%, same idea. And so it validates the way we did this study. And the mortality of scleroderma, the survival isn't great to begin with. So you see if 100% are alive at 1 year, you have some people dying from scleroderma, and you can see the survival mortality going less survival over time. But the green is if you have interstitial lung disease, your survival is doubly worse, approximately. So we want to find these patients and treat them because we want to prolong their survival and improve their quality of life. So there are patterns of interstitial lung disease progression. So one of them, but it's that green, you go, well, look at that green, they're getting better over time. That's only 5% of the patients. Stabilization, though, is about 20% of patients, and actually improvement is more than 5%. Sorry, it's about 15% will improve, another 15 to 20% will stabilize, but then you have people that rapidly progress. They're very uncommon. That's only 16 out of about 600 patients that are rapidly progressing, and they're not going to be around for more than a year, those 16% of the people with interstitial lung disease. But you have the blue people stable, and then they fall off the curve and worsen over time, or the red solid line people that sort of lose a lot of lung stuff in the first year and then kind of don't worsen as much over time. But notice how it's hard to predict who's going to worsen because there's all these patterns. We also know that if you have worse skin involvement, you get worse lung disease or higher mortality. And if you have worse lung parameters, you have higher mortality. So scleroderma, bad skin equals higher mortality, bad lungs equal higher mortality. So some predictors of doing poorly in rheumatoid were men more than women, even though there's more women with rheumatoid. And scleroderma, there's again about 80% women, 20% men, even sometimes 90% women. Men get more diffuse subset, diffuse and male gender have more interstitial lung disease. Some antibodies we look at, some inflammation markers might also be helpful, and also following the lung disease by their high-res CT, bad high-resolution CT, bad CAT scan, in other words, of their lungs, they'll do worse. So having that honeycombing is worse, and having worsening lung function or worsening lung CT is not good. So again, we treat, just like in rheumatoid arthritis, we treat in 2 ways. immune suppression, antifibrotics. So the immune suppression is mycophenolate mofetil, if not cyclophosphamide, if not considering tocilizumab or rituximab. Tocilizumab is Actemra. That's the one that I mentioned has been shown to help COVID for the bad, severe COVID patients. The antifibrotics, nintedanib, and probably pirfenidone. So this is the nintedanib trial that was done just its own trial in scleroderma patients. And again, you see worsening lung function. That's the dark blue in nintedanib, but double the worsening, which is the light blue on placebo. So you'd rather be on the active treatment. And another way to look at it is following the blue over time of worsening and a bit of stabilization or less worsening by about 12 weeks. Your worsening levels out, but on placebo, it continues to worsen.
Excuse me, Dr. Pope, someone
Yeah.
wanted to ask you, you're talking about the trial for nintedanib that shows the results, but where could they find out about the results for pirfenidone? Who's conducting that?
Oh, see, so you're reading my mind, whoever asked that, because ta-da, pirfenidone. So the reason I said question mark on each trial thing is the rheumatoid trial isn't out yet. And this is a trial of progressing pulmonary fibrosis other than other than idiopathic pulmonary fibrosis. But there's a little bit of interest with this trial because, and I'll explain it. So we don't have the Health Canada indication yet, but I think we will. So that's why I have a question mark as well. So one of these trials took a long time to enroll. So they stopped the trial before it was fully enrolled, and then it was a positive result. And they said, oh no, we should have enrolled everyone. What do we do with the results? So that it was stopped because they have a feasibility or futility, but it was actually positive. So the pirfenidone study, here's one of them, Relief. So this was scleroderma, rheumatoid, sarcoid, idiopathic pulmonary fibrosis that wasn't IPF, so weirder ones, hypersensitivity pneumonitis. It's a grab bag of pulmonary fibrosis, but not your traditional IPF patients. And so they found less worsening of the lungs. They found more favorable mortality as well. So it looked pretty positive, which went on to the phase 3 trial. And the phase 3 trial, these are some of the results here, but we don't have all the results published yet. And we don't have Health Canada indication yet.
Is this research being conducted through one of the pharmas?
Yes, so pirfenidone is made by Roche, and in US, Roche is Genentech as well. And nintedanib is Boehringer Ingelheim. So the pharma, these are just such large trials that cost a lot of money, have to be multiple sites, multiple countries. So that's why we have to have these where pharma is paying the bill, so to speak. But there are some investigator-initiated trials, but they're usually single site or smaller that don't always give definitive results. So that's an excellent question as well.
Okay, someone also had a question. They said that they were on OFEV, but they had some bad reactions. And so they're on it on one now. And then they got changed to, they changed their IBD med to Entoviable, ENTYVIO.
Entyvio, but
Entyvio,
that's
yes.
yeah, so change the IVD. Okay, so that's a different thing. So there is nintedanib and pirfenidone. Up to 1/3 of patients don't tolerate those drugs, but if you go down on the dose a bit, you can usually get better tolerability, but that's for pulmonary fibrosis. And basically, less dose is better than no dose. So that's the one thing. Now, sometimes it's a bad tolerability. So then if you have pulmonary fibrosis, they'll switch from, say, if you're on one of them, say nintedanib, they might then switch you to pirfenidone or vice versa. Now, this patient is very complicated as well because they have interstitial lung disease or inflammatory bowel disease like Crohn's or ulcerative colitis, which is not related to pulmonary fibrosis per se. And so two problems, and Entyvio doesn't probably do anything good or bad for the lungs, but can help the inflammatory bowel disease. So it's a different biological, but usually they're going to keep the nintedanib, and one a day is better than none of nintedanib, and then they might switch over to pirfenidone if there isn't tolerability. So good question, and it shows how complicated people can be. So Judy, well done on that question that you put in. Yep. So pirfenidone, probably it will be approved in Canada for less worsening, less progression of pulmonary fibrosis other than idiopathic. It's already approved in idiopathic pulmonary fibrosis. So we will eventually get the approvals, but I put a question mark because we don't know all the data for scleroderma or rheumatoid yet, and the rheumatoid trial isn't fully, the results aren't all out yet.
Okay,
So
thank you.
then yep.
Thank you.
So, yep. So the next question is, can tocilizumab, that's an anti-IL-6 biological drug, reduce scleroderma interstitial lung disease? Well, it's approved for that now in United States. So they made an announcement in March. FDA said that this drug called Actemra or tocilizumab, in Europe it's called Actemra, seemed to preserve or less worsening of lung function in the early scleroderma patients with bad skin involvement. So it wasn't a lung study, but they looked at the lung results in those patients, and the patients driving the data for lungs were the ones that already had lung involvement. Like 15% of my patients will have clinically relevant lung disease with scleroderma. So there's trials showing skin involvement, where that was the primary outcome. So it helped skin a bit. The blue, it kind of leveled a little bit better and leveled, but the red, it kept improving. But what you see here is you want to be the red that shifts your lung function over to the good way. So shifting your lung function here to a better improvement is the red, the tocilizumab or Actemra, compared to the blue, the placebo. So that was the phase 2 trial. Same stuff was shown in the phase 3 trial of Actemra or tocilizumab for early active diffuse systemic sclerosis, the diffuse subset of scleroderma. So you would rather have less worsening. So you can see that 70% on placebo worsened lung function, 50% on active drug worsened lung function. The one way of looking at it. The other way of looking at it, again, worsening lung function in 3/4 on placebo, only 1/2 on active treatment. But some were still worsening even though on treatment, but more were worsening on the placebo.
Dr. Pope, somebody wanted to know, do you usually combine rituximab and Metrotix for patients with RA and PF?
Yes, so if you have rheumatoid arthritis and interstitial lung disease with IPF, I would use the methotrexate, but the respirologist and the rheumatologist talk together, and we add rituximab. So we use rituximab with methotrexate all the time in active joint involvement. If the respirologist said, I don't want methotrexate anymore, you can use rituximab on its own, or you can use rituximab and add that CellCept MMF, mycophenolate, or myfortic drug. That's the CellCept kind of drug, or MMF drug. So we do combine rituximab with other stuff. Absolutely, yes. So great question. So now there is a treatment algorithm that's relatively recently published for interstitial lung disease and scleroderma. And what you really want to know is how are you going to treat it? So they're saying mycophenolate mofetil, if not cyclophosphamide, or thinking about drugs like rituximab, and now we'll say drugs like Actemra, but also nintedanib if you have the fibrotic pattern. If you just have the fluffy, looks like it's kind of all inflamed, but you don't have the Swiss cheese holes, you might not yet consider a nintedanib. If you have lots of holes, meaning irreversible damage, honeycombing, so it looks like honeycomb or it looks like holes in a sponge, that's bad for your lungs. I would, in that patient, consider nintedanib in addition to immune suppression. So this is another criteria here. And again, looking in scleroderma, all sorts of treatment criteria just recently published November of last year. But look at what they say: interstitial lung disease, mycophenolate mofetil, nintedanib, cyclophosphamide, rituximab, tocilizumab, maybe giving a stem cell transplant, and also possibly needing lung transplantation, and question mark maybe pirfenidone, because we don't have the approvals and we don't have all the data public yet in scleroderma for interstitial lung disease in those trials. We need the subset trials. So you can see there's a lot of interest in scleroderma lung, a lot of hope for our patients. So what about patients who are interstitial lung disease and maybe have a connective tissue disease? So these are patients that are called, they have a name and you don't have to know the name, but it's kind of incomplete autoimmune disease. So it's called interstitial pneumonitis with autoimmune features. So you have something, but I can't fully, as the rheumatologist, I can't fully diagnose you with rheumatoid or scleroderma or myositis, etc. So it's the presence of interstitial lung disease. So you got to have interstitial lung disease if you have IPAF. You exclude other reasons for it, like sarcoid, like hypersensitivity pneumonitis, all the things that the respirologists know what to do. They don't meet full criteria for a connective tissue disease, but they have two of signs of a connective tissue disease, one of them or two signs. They have a positive autoantibody and they have the high resolution CT. So maybe it's someone with JO1 positive, that's an antibody, and ILD. Maybe it's someone with myositis rash, but not dermatomyositis yet, and having interstitial lung disease. So these are some of the clinical signs that we would look for. So those patients, I just tend as a rheumatologist, just treat them like the disease they're closest to. So I will still treat you, even though we don't know your full label, if you need treatment. So these are the data from the pirfenidone in patients with unclassifiable progressive fibrosing interstitial lung disease. And basically, I showed you some of the data earlier, and this was published online September 2019, but we need to know more of the data over time to really know, and we need to get Health Canada to approve this indication, or you won't get access usually because these drugs are so expensive, but it can be helpful. Then there's actually patients with inflammatory myositis. So myositis is dermatomyositis or polymyositis. And to get lung disease with inflammatory myositis or polymyositis or dermatomyositis, they either have the anti-synthetase antibodies, most of which are this JO1. That's just a blood test. So you think, what the heck am I talking about? Doesn't matter. It's just the name of a blood test. Or they have this other blood test for, these are autoantibodies called MDA5. If you're MDA5 and you have dermatomyositis, you can have rapidly progressive lung disease, and it is then in those patients basically a medical emergency. They often present really sick in the intensive care unit, and then someone figures out what they have because they have, say, a dermatomyositis rash. And we really give strong immune suppression for those patients because it can be very rapidly progressive and end to their demise quite quickly if we don't get on with treatment. So now looking here, I think it's important to note that I talked about some diseases. I didn't talk about lupus. I didn't talk much about myositis. I didn't talk about Sjogren's. I think it's important that you get your information from websites that are credible. And also I gave you Canadian websites, their logos, because you can look at the US websites, which by the way, often give really good information, but sometimes the treatment algorithms will be different because of access to certain meds in the US versus Canada. But the US websites are very credible for most patients, and that would go looking depending on the disease you have. So I'd like to kind of think of stopping here and have patients ask questions. And I must always say, for my research, I always thank the associations because some have funded our cohorts and things, but also I have to really thank the patients, because without patients. I'm a clinician and an epidemiologist, so I do clinical research. So without all my patients volunteering for a lot of studies, I wouldn't be further ahead in the knowledge to help other patients. So kudos always to patients for giving up their time, their blood, sometimes skin or other biopsies to help us understand what's going on. So I'm going to stop sharing my screen, and Sharon, you can invite other questions, and you also, I think, had some questions in advance to ask me.
Yes, thank you, Dr. Pope. One of the questions that was in the chat room was that, should someone with this condition get a third dose of the COVID vaccination?
So the answer is, and I'm answering that way because right now in the United States, the answer is yes. In Quebec, if you're on certain biological drugs, the answer is yes. In Quebec, if you have certain immune suppression conditions, the answer is yes, but not all conditions, by the way. In Alberta, the answer is maybe, because they're giving boosters for certain biological drug use. And in Ontario, the only patients that I can currently recommend a booster for, I can recommend it to anyone, but the only patients who in Ontario will get a booster right now is patients on rituximab. No other rheumatology patients are eligible to get a booster right now. Will this change? Probably, but it will change as we get more data from studies. But studies are showing that patients with these autoimmune conditions, because I'm talking about connective tissue diseases now, are at higher risk of getting more severe COVID. So you're not at higher risk necessarily of getting COVID, but higher risk if you get COVID of more severe COVID, number one. And number two, rituximab for sure, but other drugs like high-dose prednisone, Cellcept, which is mycophenolate mofetil, and maybe some biologicals and maybe even methotrexate will decrease the chance, and I said a lot of maybes in there, decrease the chance of getting a good immune response to your first two COVID vaccines, which is why a booster might be important. So in the US, absolutely yes. In Canada, we can't offer it to everyone yet. So I think the answer is and will eventually be yes. But right now, don't bother phoning your rheumatologist. Only if you're on rituximab in Ontario can we give you the letter. In Alberta and Quebec, I don't think you need a letter. You just have to prove a pharmacy record of what you're taking, I think. And it changes every minute of every day.
Okay, thank you. Dr. Pope, a couple of people had asked if, if they had COVID and they're wondering, would that cause them RA or scleroderma because they're feeling like their joints are a little stiff, so they're kind of worried. Do you know if that's something?
Right. So I'm going to answer this in two ways. So I'm going to answer it not what you asked, and then I will answer what you asked. So there is another sort of opposite question. If you have rheumatoid or scleroderma or lupus, will your disease flare if you get COVID or even after the COVID vaccination? So after the COVID vaccination, seeing flares of our autoimmune diseases can happen, very rare, and looks very self-limited, very uncommon to flare your disease from the COVID vaccination, and very self-limited, meaning very short flare. And that's my impression, and it's been proven by some other sites as well. For getting COVID, will it flare your condition? Maybe. Will it worsen your interstitial lung disease? Maybe. So if you have COVID in your lungs, 2 lung problems is worse than 1 lung problem. So if you already had interstitial lung disease or idiopathic, well, it's not idiopathic. If you had pulmonary fibrosis or ILD, interstitial lung disease, from connective tissue disease conditions, and you get COVID, it could worsen your condition there, but it doesn't always, shockingly, because some people have very mild COVID. Even my patients heavily immune suppressed, some have had very mild COVID. Now, the other way around is if you are unlucky enough to have COVID infection, or do you have a higher chance of getting rheumatoid, lupus, polymyalgia rheumatica, et cetera, et cetera, et cetera? Will kids have more juvenile arthritis risk? And the answer right now is we're not sure. So we have to realize there's a baseline risk of getting these conditions year after year. And I told you the incidence of, well, I didn't tell you, but it was on that one slide. We know the incidence of scleroderma in Ontario by a 10-year study of 3,000 patients. So we know the incidence. Will COVID increase that incidence further? I don't know. I won't be able to tell you for about 10 years because it takes a long time to know if it blips and comes back down. But some viral illnesses can increase your chance of autoimmune diseases, and maybe COVID will be one of them. But in honesty, we think the risk will be very, very, very small. But there are patients with COVID who feel achy for a long, long time. They don't just feel really exhausted and fatigued, they can feel very achy. And many of the COVID patients, like the patients who got COVID that I see, do not currently have a diagnosis I can make other than joint pain, arthralgias. But most of them that I've seen do not have inflammatory arthritis. So give it time would be my answer. But most of our conditions, that even though a viral illness can increase the chance of getting those conditions, that is only the minority of all the people I see every year. And we've done research on does influenza give more rheumatoid? And the bottom line is it did, but it was such a little risk, it was irrelevant. It increased rheumatoid by such a low amount that getting rheumatoid for other reasons was far more common. The other reasons meaning, I don't know. The most common reason of getting all these diseases is, I don't know.
Okay. Next question is that someone was diagnosed with RA, scleroderma, and ILD in 2007. How would they know whether RA or scleroderma caused their ILD, and why would it matter?
So we don't know what, like one, the other, both, or neither caused it, but it matters because the treatment might be different. So if you have interstitial lung disease and it's stable for a decade, I don't worry about you until you aspirate or something like that. If you have new shortness of breath, I worry about you far more. But if I don't know if it's stable or if it's worsening, it matters a little bit because we're going to end up treating you by the pattern of your CT scan. And we're going to end up treating you depending on, are you worsening a lot or a little? So I hit a slide because it's kind of, I don't want to give the wrong message, but I hit a slide that this year in my talk, this year, there was a study that just came out, in fact, looking that CellCept didn't seem to help mild interstitial lung disease, but it probably could have helped. The study was small. It wasn't a randomized controlled trial. The study was small and the study was short. If you only have mild interstitial lung disease, I might need 5 years of immune suppression to actually know if it's making a difference in your life. 48 weeks isn't like a year, probably isn't long enough to know. So for someone with stable interstitial lung disease, you might need close follow-up. By close, I mean periodic interstitial looks by your CT scan, and certainly more oftenly doing your breathing test, your pulmonary function test. And we still don't always know to trigger and whom to treat or not. And that's where you get the brain of your lung doctor and the brain of your specialist together to kind of figure it out.
Okay. Dr. Pope, there's another question that I received in advance. Someone wanted to know, how can they get moved to the head of the line when they're trying to get referred to an ILD respirologist? It seems it takes a long time. They've been waiting for 8 months and they're just very concerned because they feel like they're worsening. And so, how do they do that without, because they don't know who they're being referred to? How do they get their rheumatologist to kind of,
Right. So make noise. So as a patient, make noise and then get your doctor that's referring to advocate for you. So squeaky wheels do get greased more than quiet wheels. So I always say to my patients, if you're worsening, whether you're on a wait list for, oh my gosh, a hip or a knee replacement, which is forever now with add in the long wait and then add the COVID canceled ORs. But so squeak and I'll keep advocating for you. But also it's the same as if I've referred you to someone and I haven't heard back, because now in a lot of referral systems, the patient is contacted directly from the referring physician's office. Usually they give a courtesy fax to the referring physician's office, but I don't know until I get that fax, like, oh my gosh, you sat on a wait list and we don't even know, you have no date. And now the date is so far, I will advocate, but sometimes we miss it. We forget that, oh, is the date date, like, oh, I thought it was 2021. You mean December 2022? That's horrible. So squeak, let your referring physician, the specialist, know, by the way, I feel I'm getting worse and I'm on a waiting list. I don't know who I'm seeing, because then there's two things. You squeak and get like you complain to your referring physician so that they can advocate, and they get often their secretary to fax the other secretary saying, this is important, patient worsening, or if there's more data, CT scan is really bad, or CT scan's worsening, or I redid pulmonary function because they were canceled during COVID and now I got them and they're not very good. Please help. Can you see soon? That kind of squeaking, the doctor faxing or the secretary faxing on behalf of the doctor to the other doctor is important. The doctor picking up the phone would be helpful, but in honesty, I fax, or if I know the doctor, I email them, but I don't know every doctor's email for sure. And I don't know everyone, but we have to advocate for our patients. That is what we're supposed to do. And the patient or their family has to advocate for them as well. So that's not hounding the referring physician's office. You get, oh, you're refused to doctor, or you're referred to Dr. X in Toronto. You can say then to that office, I'm willing to come at any time if there's a cancellation list. I am worse. Could you let the doctor know that I feel worse? So my doctor's going to fax you and get the ball rolling more quickly. There's no harm in doing that. Or finally, I'll say, I do it all the time, not for subspecialty like this, but say I do have patients from all over the place. Is there someone closer to home while they're waiting to come to Toronto that can help co-manage? Because I'll tell you, most respirologists, adult respirologists, know how to treat IPF. There's IPF centers of excellence, but every respirologist who sees clinical patients pretty much, unless if they just do a CF clinic or something like that, pretty much knows how to treat IPF. And treating IPF with those fancy drugs are very similar to how we would treat fibrosing connective tissue disease. But in addition, I would use, as a rheumatologist, my immune suppressives. So I have patients that say from Thunder Bay that I might be getting, that they'll get their lung care because they're bad enough, say in Toronto, they're getting their rheumatology care in London, but there are Thunder Bay experts that I can help be in the circle of care. And also it's important everyone talks to everyone else. So when I dictate, I try to make sure everybody in the circle of care gets a note, or who am I talking to to really advocate for my patient, and also to give information.
So Dr. Pope, this person wanted to know then, how long do you think they should wait before they go back to their referring physician to say, look, it's been 3 months, 4 months?
If you're worsening, then you don't wait any longer. So if you are worsening of your breathing while you're waiting to see a lung doctor, that's a reason to be seen. And it could be something else treatable. It could be asthma for all I know. You don't have to have just one lung problem. Lots of people have obstructive lung disease or reversible airways disease in addition to interstitial lung disease. So sometimes there's something else going on that's treatable. Or I might have to get a person to stop aspirating. So for instance, with scleroderma, the swallowing tube doesn't work. And so we need to stop aspiration because aspiration progresses lung disease. So for instance, so if you're worsening while on a waiting list, you've waited long enough to go back and say, please advocate, I'm desperate. Okay, but with COVID, it's not easy, but just squeak, please.
So this person said, then you're saying that they don't always have to go to a center of excellence to get treatment of this disease, that they can go to any community respirologist and they'll know how to treat the disease. Is that what you're saying, Dr. Paul?
They'll know the starting, or they'll know to then also get a hold of their colleague. For instance, I have patients treated in, I'm just going to say small town Ontario, okay? It's not that small because there's a respirologist present, but I'm not talking like the giant centers. And that respirologist co-manages with the Center of Excellence and for lungs, and co-manages with me because my patient and we are kind of a center of excellence for certain rheumatic diseases as well. And we can do that. And if they can trigger the start of treatment, and they can sometimes nudge or squeak to get the center of excellence of the lung side involved more quickly. But so just, so a big city has centers of excellence, but we have medium-sized cities. Most of Canada is rural, small town, medium-sized cities, right? So most people don't live in the big city, even though lots of people live in the big cities. So just say, can we get someone locally to co-manage while we're waiting?
Okay. And Dr. Pope, when the referring physician makes that referral and then they finally go see the respirologist, does the referring physician ever get a report back about their condition? Because this patient's wondering, like, are they responsible for coming back to see someone like you to say, hey, I finally got the referral, I saw the specialist, this is what they told me? Or will you actually get a report? So then you might call them up and say, I saw your report, and I think we're going to have to do a different treatment for you given,
Right, right. So if I was a referring physician, I should get a report, but in honesty, we are a teaching center as are other centers of excellence. So sometimes the trainee, as a for instance, only dictates to the family doc, not to the referring physician. It's a bane of my existence. I never see the pulmonary function test. So I do, but I have to track them down. And I do because I need to see them because I actually kind of get it. Even though I'm a rheumatologist, I kind of get the respirology side. I'm not a respirologist. I can't bronch you. I don't treat asthma well. I'm not that kind of I'm not a respirologist, but because I have a captive audience of patients with interstitial lung disease, I have learned more than the usual rheumatologist. So I'm a really good rheumatologist. I'm not a respirologist, but I've learned some rest. So I need the pulmonary function test because if they say they're about stable, that's like telling someone, if I said to the family doc, I want you to treat this patient's blood pressure, they go, okay, what is it? They can easily do a blood pressure, but they'd say, what is it you want me to treat, but you're not giving me the numbers. I need the numbers to say you're the same, you're slowly declining. Anyone can tell that you're rapidly declining because you'd probably feel more short of breath, but also they'd say, oh, it's a rapid decline. But if they say the PFTs are stable could be slight worsening. I need to know that. So I graph the numbers, I get the numbers and plot them on the dates. So I need to get your breathing tests, which in most of Canada are not on the electronic medical record system. In some parts and in some labs they are. And then there's also sometimes we don't get the full pulmonary function. So you might get your breathing test in small town, but we need to do the full later in big city because in big city, I can get your diffusing capacity. So there's flows and volumes. You can do flows well in any pulmonary lab. We don't always get the volumes and diffusing capacity except for the bigger labs. So I mean, by a little lab can do flows really well, but doesn't always do the rest.
Okay. And so someone wanted to know, where would they start to find a therapy / breathing exercise program for PF?
Right, in the Toronto area. So number one, I sneak people into cardiac rehab. So you don't have a heart condition necessarily at all. You didn't have a heart attack. You don't have heart failure. The same for cardiac rehab is what we tend to do for lung rehab. And it's also the same for the cold program, chronic obstructive lung disease or COPD programs. It's the same rehab, but we're doing it for interstitial lung disease. So we try to sneak you into those programs, and you can look online for cardiac rehab. It's easier to get you in a lung rehab like chronic obstructive lung disease or emphysema rehab. But you know who knows it? Your respirologist, your rheumatologist might not know. And in the meantime, you'd contact great experts like Sharon and her group, because they probably say, here's the resources. We want you to exercise even though you're short of breath. We want you to look at these YouTube videos, but that does not replace medical observation. Okay. So we can give you some stuff to do, but you need your doctors to really tell you more thoroughly what to do. So you can look. So in a general, we used to think when I first trained, if you had obstructive lung disease, or in this case that we're talking about interstitial lung disease, we just let you sit there. And we said, oh, if you exercise, you'll go like low oxygen and that's worse for you. We now know exercise prolongs your survival. So it's really important to exercise. But your lung doctor in Toronto will know, your rheumatologist might not know, but you could say even to your family doc, can you get me in the emphysema program? Because all the slots aren't always filled. And then you don't have emphysema, but we make exemptions. I've gotten people in Kitchener-Waterloo in the emphysema program, even though they have interstitial lung disease. I've gotten them in cardiac rehab here in London because the other program was full for the ILD program. So we just sneak them in places. You got to be kind of smart about this.
Dr. Pope, someone just mentioned that, as a rheumatologist, you're so knowledgeable about PF and everything else. Like, how would they go about finding out if their rheumatologist would have sort of similar experience or knowledge that you have? Because it seems that, sometimes even though you're with a great rheumatologist, but they don't understand the disease, they might hold you back.
Right. So there's two things. First of all, we all know different things. So I didn't know when I first started practice, even though I was at the beginning, I tried to be a scleroderma expert. Now I really am. I'm also an expert in RA. I'm an expert in some other connective tissue diseases. So I can't know everything about everything, right? And nor can your regular, really good or even excellent subspecialist. But what you can do, and again, this is part of squeaking and it's part of not, you never want to tick off a doctor because that ends a therapeutic relationship or makes it not as good for you or them, right? But you can self-advocate. You can say, I saw this lecture, and you don't come in with 2 pages because that really it doesn't tick me off because I have a lot of trainees to read the 2 pages of questions and I just answer them while I'm like reviewing the patient and write the answer in while we talk because I'm multitasking. But if you go in with a solution, it's kind of like if you're advocating to your MP or MPP for anything, including your lung disease, getting drugs covered, whatever. If you go in with a solution, you're far more apt to be heard and listened to and acted upon. So the solution is, you don't say, I think you're holding me back. The solution is, I have a lung doctor. You're a great rheumatologist. Thank you so much. Do you think I need to be referred to an expert site because I think I'm worsening or because I want to know more? And they might go, no, because I think you're really stable, or sure, why not? The system will pay for it. It's no skin off their nose, so to speak, other than doing a referral. So I see, I won't call it second opinions. I see co-management opinions all the time on bad RA as a for instance, but also on scleroderma all the time because scleroderma is rare. So most rheumatologists can't know as much about it. It's just too rare for them to, delve deeply if they're not doing research in the area. So you can say, so that's the solution. You come in, instead of saying you might be holding me back, you come in with a solution. I'd like, if you think it's okay, to get an opinion from an expert site, just because I have a lot of questions and I don't want to take up your time with questions that might be kind of obscure. Right? That's a great way to broach it. And that's people skills too, but it's squeak and you might get an answer. But if you go, like, you'd never say, I don't think you know anything about this, like you're holding me back, but you can think it and it might be true. I'm holding people back if they have lung cancer because I don't know how to treat it. I send them to an oncologist, right? We can't know everything about everything. So if someone says, I'd like to know more, and I realize there are sites where they do research and stuff like that, I'm interested in more knowledge, but also maybe in research, no one's going to say no.
Okay.
Usually.
Dr. Pope, in your slide presentation, you said that 1 in 6 patients with scleroderma ILD will die from PF. So if someone has scleroderma, how long should they, when they have this disease, should they maybe push a bit to say, maybe I should get my lungs looked at, or should they do that right away and say, look, we should keep it lungs?
Right. So in all early diffuse scleroderma patients, and in all scleroderma patients who have this one antibody called SCL70 or called topoisomerase 1, and don't worry about it, the rheumatologists know those, you will have your lungs screened for. Absolutely. And almost all sclerodermas will have their lungs screened for, because we're looking at the gas exchange, because we have recommendations to screen all scleroderma patients for pulmonary hypertension, especially long-standing, especially older age, longer disease duration, limited subset gets pulmonary hypertension. So virtually all scleroderma patients get breathing tests done periodically. So they're all screened for. Now, if you have 10 years of scleroderma and you run 5K 3 times a week, we might not be screening because you're fine. But if you run 5Ks a few times a week and you say, I'm more short of breath now when I run, I'll screen you anyway. but you're kind of doing the screen for me because you've actually, you've screened by saying I have excellent exercise capacity until I might be a bit short of breath. But many patients don't know if they're short of breath because you have such a bad disease, you're in pain, you can't move right, you might have skin ulcers, your guts don't work right with scleroderma. And so you don't even realize you're short of breath because you've changed your behavior so much, which is why we screen. Now, Dr. Holly has a really good thing in the chat that I might just mention, and this is really important to note, that pulmonary rehab is so important and needs to be funded in smaller centers. So there you go. We have an election coming, but by the way, healthcare, of course, we know is provincial. So when the next provincial elections come in your area, go in with a solution, meet with your MPP, because your MP will say, yeah, that's great, but it's not a national strategy. So meet with your MPP and say, and meet and organize, say, we need in our area, because I live in, I don't know if Guelph has one. I live in Guelph, or I live in Woodstock, or I live in, somewhere on Vancouver Island, Nanaimo, and we need pulmonary rehab because it saves it prolongs survival, improves quality and quantity of life. And because it's cheap, it's way cheaper than a bunch of drugs that you might need too, but it's a pretty inexpensive thing. So advocate. So that's your solution when you squeak and go to your provincial area, because your local person wants your votes, and locally is where you need to get your pulmonary rehab if you can. You're not going to drive 2 hours each way to get an exercise program that's guided, right? It doesn't make sense.
So Dr. Pope, at the Canadian Pulmonary Fibrosis Foundation, we have links to online exercise programs, and they're very helpful, so that even during COVID time, or if you're not living in a large center, you can do many of these exercises on your own without any kind of special equipment at all. And they're just great little routines to help maintain your good health. So I would tell your audience that, come out and check it out at cpff.ca. In the meantime, I realize that we're coming almost to the end of our presentation. Is there anyone else with any other questions for Dr. Pope? Because it's a rare opportunity for you to ask someone who's not only a mentor to many of the new and upcoming rheumatologists, but she teaches and she actually understands both sides of the field, which is so rare, because many times people understand the lung, but they won't understand the connective tissues, or they understand the connective tissues, but they don't understand the lung. And so we have a very rare opportunity here for us to share with Dr. Pope. All right, then. Seeing none, I want to say thank you very much, Dr. Pope. I so appreciate you coming back again this year. I've learned so much, as I did last year, and I hope our audience felt this very helpful as well.
Great, thank you. And thank you, Sharon, for all you do. And also your association is very, very important for my patients and so many others as well. So thanks for, it's really a labor of love what you and others do. So thank you. Okay. And thanks everyone for attending, and have a good fall, and you'll be informed about boosters because the data will change over time in your own province. Yep. Take care.
Take care. Thank you.
Yeah. Bye-bye.